Hello and welcome to the webinar on youth services for alcohol and other drugs and the latest on e-cigarettes. My name is Pat Simmons from the Sydney North Health Network. We wish to acknowledge Australia's Aboriginal people as the custodians of this land. We pay respect and recognise their unique cultures and customs and honour their elders past, present and future, and extend that respect to Aboriginal people attending today. The presenters that we have today is Kingsley Waterson from Drug and Alcohol, Carolyn Mack from ESTEC, Michelle Comito from DAYS, Marlene Gilbert from Mission Australia, Lisa Faulkner from KIMS, Christian Guinow from Odyssey House, Jane Dematteis from Brookvale Headspace, and Ryan Courtney and Professor Hayden McRobbie from NDARC. Our first presenter is the Northern Sydney Local Health District Director of Drug and Alcohol Services, Kingsley Waterson.
Yes, good morning and welcome to this morning's webinar. Look, I'll open with some statements that came from a review of drug and alcohol services in Northern Sydney that were undertaken in 2017 as a part of our 10-year planning processes. They were: demand for drug and alcohol services within emergency departments is growing faster than population growth. Young people account for a substantial proportion of these drug and alcohol emergency department presentations. And approximately 7% of all drug and alcohol admissions through the emergency department in Northern Sydney relate to people under the age of 18 years of age. These statements were underpinned by data that has provided a framework for service planning by ourselves, the primary health network, and then on to our non-government service providers. These statements provide an indication of what we see at an emergency department level. What they don't show is the extent of problematic drug and alcohol use that it actually exists out there further amongst youth in our communities. Services across Northern Sydney are a matrix of both government and non-government services that work together in the service provision for young people. We meet regularly to work through methods by which we can best complement each other, coordinate care delivery and service integration, and to ensure that a wraparound response is provided to the community by our services. Throughout this webinar, you will hear from a range of providers what services they offer, their locations, and how to make contact. Northern Sydney Local Health District government-funded drug and alcohol services offer outpatient counselling services on all hospital sites throughout Northern Sydney Health, opioid treatment services, merit programs, which are magistrates' early referral into treatment, inpatient services, both voluntary and involuntary, and liaison services to our hospitals, emergency departments and ward areas. These services are largely services for 18+ years of age, and people can be self-referred. They require no supporting GP letter. The only instance where we require a GP referral is in the circumstances of specialist medical clinics. We can be contacted through our centralised intake number to any of these services, which is 1300 889 788, Monday to Friday, 8:30 to 5 p.m. What was my next bit was, oh yes, and now basically our next speaker is Carolyn Mack, the CEO for Sydney Drug Education and Counselling Services.
Thank you, Kingsley. Welcome everybody, thank you for joining us. At ESTEC, we specialise in providing individual evidence-based counselling and support for young people aged from 12 to 25 years who are impacted by any issues that relate to alcohol and/or any other drug use. Our team of qualified and experienced counsellors are also able to work with any co-occurring mental health concerns. And probably about over 80% of the young people who present to us would have some sort of co-occurring mental health concerns. We currently have a team of 10 counsellors and can provide services to any young person who's living, working or studying within the Northern Sydney region. Our services are free and no Medicare card is required. Currently, we're providing face-to-face sessions at St Leonard's and Manly with telehealth available as an option where appropriate or required. We work with each young person on their individual goals within a harm minimisation framework. Our work is trauma-informed and family inclusive. We actively encourage self-referral where possible from the young person, but also accept referrals from any professional or service provider, as long as the referrer can confirm consent of the young person. For young people under the age of 14, we do require the active consent from a parent or guardian prior to treatment, and we'll arrange a meeting with one of our counsellors with the parent or carer to discuss this. For young people aged over 14, we will assess for consent, but they do not need parent consent. We aim to offer an initial appointment for a young person within 1 week wherever possible, and with follow-up quickly after that. We work in collaboration with a range of other services to help meet a young person's needs and are very happy to support warm referrals or introductions where that is helpful. And we have found that Zoom can actually be a helpful tool in that regard as well. If you are concerned about a young person you're working with and the impact of their substance use and any co-occurring mental health issues, we really do encourage you to reach out to our team and discuss how we might support you and, if appropriate, facilitate an introduction or referral. SDEC also offers support and counselling for family members, including our highly regarded 6-week Paving Ways group, which is an intensive parent support group for parents or for primary carers who are impacted by their young person's problematic alcohol or other drug use. We can work with a parent, a young person, or both a parent and a young person at the same time or different times. We really encourage parents impacted by their child's problematic substance use to reach out to us, even if their young person is not currently accessing the service. Parents do need to contact SDEC directly to make a referral for their own support. We are very fortunate to have a psychiatrist who regularly consults with our clinical team, and young people attending for counselling with SDEC may, where assessed as appropriate by their counsellor, be referred for a psychiatric assessment. At SDEC, we're also able to provide professional development opportunities for professionals and services across the region related to working with young people impacted by substance use and co-occurring mental health issues. If you would like to make a referral or are looking for information or support, we really encourage you to contact our team on 9977 0711 Monday to Friday between 9 and 6. And our contact details are on the slide. Thank you so much for your time. It's my pleasure to introduce our next speaker, Michelle Comito, Coordinator Family and Youth Support Services with the DAYS team.
Thanks so much, Carolyn. I'm Michelle and I am from the DAYS team, which stands for Drug and Alcohol Youth Support Service. So we are a service funded by New South Wales Health in order to deliver an outreach model to young people who are affected by drugs and alcohol. The big focus of our service is also to support and complement the clinical type services in our field. And so some of those clinical type services are here in this webinar today. And so we will work with young people who are living or connected to the Northern Beaches or the Lower North Shore, Northern Sydney region. And they can either be living or connected, so they might go to school in that area or hang out in that area, whatever way that they are connected. We will work with young people who have low to moderate use. And so that might look like a young person experimenting for the first time, all the way through to social settings and also through to problematic use. However, our intervention with young people with problematic use is a little bit different to what we will do with young people in low to moderate. So our goal with young people with problematic use is to mentor and support them to access the clinical type services, again, which are services that will be here in this webinar today, but also places like detox and rehab facilities as well. We will support not only young people who are affected by their own consumption at any level, so that low, moderate or problematic use, but also we support young people who aren't consuming themselves but are affected by somebody else's consumption. So that might be a parent, a sibling, a peer group, etc. Now, our staff are highly qualified and provide counselling, case management or mentoring. And as I said, it is an outreach model. So we're able to go out and see young people at school, at home, in the park or in an appropriate setting. And that is how we can use our model to support the clinical type services. And so if a clinical service is finding it difficult to engage a young person, we're able to provide that support out in their home or in the community. We support young people aged between 12 to 24, as well as parents of young people as well. We're lucky enough that our day service sits within a larger organisation of Catholic Care, which provides a range of different services to vulnerable communities and families. And so we are able to offer a wraparound support to young people alongside those clinical services where appropriate. Apart from our one-on-one support, we also provide a whole range of programs in schools and in the community. So a part of our funding is to specialise in providing drug and alcohol education programs in schools, as well as smaller therapeutic groups as well. So we are already involved in a number of schools in the region around drug and alcohol education, and we can cater to the certain trends and themes that are happening within schools at the moment. We also provide smaller therapeutic groups, and we use an alternative way to engage young people. So the day service really strives themselves on how we can engage young people through their intervention. So we use activities such as boxing, drumming, art therapy in order to engage young people through the topics and through the process of drug and alcohol impacts. And so another part we've got is our outreach model, where we do also support larger events, youth festivals, music events that are happening out in the community in order to promote safe partying. The whole model of the day service is based on a harm minimisation approach, and all of our assessment tools and all of our programs are backed by evidence and research. We are always trying to keep up to date with the most recent research and what is happening throughout trends in the drug and alcohol field in order to support our young people, but also the sector and the community as well. We do work a lot with other partners out in the community, whether that is police, schools, other community organisations as well, as we do believe that the best way to support a young person is to wrap around all the services that they need. You can refer to us directly, so a young person or a parent can refer to us directly, but also we take referrals from services, schools, or anybody else. So you are able to contact us, and our details are on the slide here as well. You can also follow us on our social media pages, where we do a lot of AOD education posts, and our tag is also on this slide as well. That's a little bit about days, but I would also really like to introduce our next speaker, who is Marlene Gilbert from Mission Australia. Marlene is the Program Manager of the AOD Continuing Coordinated Care Program.
Good morning. Thank you, Michelle. Okay, so you've got the slide there, so I'm not going to read from that, but I'll give you a bit more information in regards to what that all means. So in regards to what the Continuing Coordinated Care Program does, is that we work with anyone, as you can see, from 18 years and up, which is adult. But in regards to this session, we actually feature into the youth programs through the ages of the cohort of 18 to 25. So the aim of our program is actually to do wraparound support for anyone that presents with a drug and alcohol concern. So I guess our aim, and with the client, is the expected outcome for the client would be to maintain engagement with community-based AOD treatment, and we will do that by actually referring them to actual services, which some are actually presenting here today. The aim of it is to reduce consumption of alcohol and other drugs of concern, improve the physical health and well-being, and maximise harm associated with substance use. We would try to then improve employment, education and vocational connections for them, and we certainly would use other agencies to support us through that journey with them. The main is to maintain housing tenancies. So being part of a large organisation, we're very fortunate that we have a lot of internal other services that we actually able to attach that client to, so such as our homelessness program, and also in particular with young people in our early intervention youth services. So we would make sure that would work together with them to making sure that all the needs are being met. So the aim of it is to improve connection with family and community as well. So we would certainly look at ways that we could support the young person to communicate with family, whether it's through us or in other ways, or in regards to maybe some advocacy on their behalf. To give you an idea of what the client journey would look like is that we would expect a referral from, it can actually, as of the 1st of November, we can actually receive self-referrals as well, or from other agencies and other drug and alcohol services. So the referral will be received, and then we follow up with the client directly or with the referrer, or both. With young people, it's not unlikely that we would actually meet also with the current caseworker they may have at the time, or another service, to make them feel more comfortable. We would also then call them to meet and do an assessment, and that actually could be anywhere could be at our offices. We have offices in Brookvale, Artarmon and in Hornsby. Due to COVID restrictions at the moment, we are seeing clients in Artarmon and only in Hornsby. But certainly we're an outreach program. So we would actually go out to the young person if they feel more comfortable in meeting us in a local coffee shop near their home or near their school. We could certainly go into the school as well if that they're comfortable with that, and also meet them at a local park. Whatever is actually comfortable for them, we go to them, or even in their own homes. The aim of it is that we then build rapport to create trust and develop a relationship with them. So from there, we follow up with a meeting to do an individual support plan and to identify goals and other clinical linkages that we may need to do on their behalf. So looking at their living skills and family and community connections. From that, we then follow with a support plan, and that it's to the support plan's provided so we can look at further supports for them. So that could be anything from skills training to social engagement to education and other employment needs. And also looking at other further medical needs, such as detox and rehab or AOD counselling as well. After 3 months, we would review the progress and revisit those goals that the young person had actually set for themselves. We're very client focused, so at the same time, we actually let the client lead us. So we do it at their pace and they letting us know what their needs are, and we're supporting them along the way with that. So therefore, we can then continue and ensure needs are being met. With young people, it's hard when we talk about goals, what they are. So sometimes we actually start with them. It's about the goal is to actually find a goal. From that, we have an exit plan. So that would be to prepare the client to transition and exit from the program. And all individual support plans will include exit strategies, which will include their goals and aimed at building independence and ensuring clients have established link to ongoing support as required before exiting the service. So that's in regards to what the program can do. So you can contact us on the phone that's actually on their phone number 94802500, or you can email us as well on that email that's actually on the slide. But certainly there's a referral form, and you're welcome to call that number, and we will make sure that we actually send through a referral form. I'm happy to attach that to at the end of this, the seminar for people that may want that. I'm happy to send that through to whoever would like that today. So from that, I'd like to now introduce Lisa Faulkner, who's the Senior Clinical Social Worker of Northern Beaches Child and Youth Mental Health Services, known as KIMS. Thank you.
Thank you, Marlene. Good morning, everybody. Yes, I'm working for the Child and Youth Mental Health Service. Our main brief is mental health, as the title suggests, but of course, along with mental health, substance use can be a particular challenge, and so that's why I've been invited to this webinar to talk about the role of KIMS in liaising with all these other services and networking with the community around AOD as well as mental health. So in Northern Sydney Local Health District, there are 4 main KIMS teams that provide community-based mental health services to young people and their families who live in the catchment areas that are defined by the local council areas. There's the Northern Beaches KIMS, which is the Northern Beaches Council, the Lower North Shore KIMS, covering the areas of Mossman, Willoughby, North Sydney and Lane Cove, the Hornsby Ku-ring-gai KIMS team, covering Hornsby and Ku-ring-gai, and the Ryde KIMS team, which covers Ryde and Hunters Hill areas. There's also the School Link service, which is a liaison and networking service across the whole area. There is the Brolga Inpatient Admission Unit, which is at the Hornsby Hospital. And there's the OSCAR team, which stands for Outreach Service for Children and Adolescents, which is a team that provides a specialist, more intensive period of work, and will then refer on to the KIMS team or a private service, or potentially discharge. So who do we help? The client group for KIMS are children and young people and their families, aged 0 to 17 or 18 if the person is still at school. And the presenting problems need to be severe and complex mental health problems. The method of referral to a KIMS team, people can self-refer by calling the intake clinicians, or they can call through the mental health telephone access line after hours. We get referrals from other agencies as well, from schools, hospitals, GPs, Department of Communities and Justice, lots of other services. And we do accept referrals, but then the referrals do have to be followed up by the family or the young person. The KIMS teams are made up of social workers, psychologists, nurses, occupational therapists, family therapists, child and adolescent psychiatrists, and also psychiatry registrars. So we're a multidisciplinary team. We meet regularly to discuss the progress of the work that we're doing with families and young people and children, and we work to give a multidisciplinary perspective to try and get the best outcome for our clients. The services that we provide include assessment and referral, and liaison with other community and other health agencies. Often at the point of intake, when an initial assessment is made, initial referral is made to our team, we might find that that family or that young person does not meet the severe and complex threshold for admission to a KIMS team, which we hope is a good thing for those people. In a way, we don't like to refer people out. However, there are other services that will cover the mild to moderate presentation for mental health. So we will refer people to other services when we can. We will often do an assessment where we're unsure, and we will, after doing an assessment, then can discuss with the family which service will best meet their needs. And it may be KIMS and it may be another service. So the model that we provide is recovery oriented. It's trauma-informed services guided by evidence-based practices and collaboration. We offer a comprehensive range of assessment and treatment for infants and children and adolescents affected by the moderate to severe or complex mental health problems, or who are experiencing significant emotional and behavioural problems, including individual, family, parenting and group therapy programs at times. I think COVID has changed the way we work significantly. So it's reduced the number of groups that we're running and parent sessions that we're running. We were going mostly to telehealth for a period of time, but now we're offering face-to-face as well as telehealth. We also offer consultation and liaison mental health services for children and adolescents presenting to hospital emergency departments and inpatient wards. We work with a wide range of other services. Many of the services that you have seen speak here this morning, and the other services to come. We also do care planning with any services that are involved in the client's care and health. We regularly work with SDEC, child protection, schools, GPs. And in terms of providing feedback, with a client's consent or a family's consent, we always give feedback to GPs, and we do like to liaise with every other service involved in a family's wellbeing. So that's a little snapshot of the KIMS team. And I would now like to introduce you to Christian Guinau of Odyssey House.
Thank you very much, Lisa, and good morning, everyone. So I am here to talk to everyone about Odyssey House, New South Wales, and we are a drug and alcohol treatment provider. We are mostly known for our long-standing residential rehab, but we actually opened up a community services program, which was a brand new part of our organization about 3 to 4 years ago now, which has blossomed and grown quite a lot over the past few years, which is also the part of the organization that I work for. So I will touch upon both parts of our organization today. In terms of the client types that we do see at Odyssey House, we see adults aged 18 plus. However, many clients that access our services are between the ages of 18 to 25. And because of that, we've developed specific programs within our delivery model for those clients. We're able to see complex clients, basically clients of any alcohol and other drug complexity, because of the fact that we've got a wide range of services available within Odyssey House that people can also get referred onto. For example, if they go into the community services program and that doesn't meet their needs, we can then also consider other options in terms of higher order treatment. It's also important to point out that we see a lot of clients with co-occurring conditions such as alcohol and drug addiction and maybe mental health disorders. So given that, we are able to work with medium to high complexity mental health in the sense that this may be managed by internal psychologists or internal psychiatrists, or we also work in close collaboration with other providers that deliver specific mental health service external to that, just depending on the client. So a good example for it would be Marlene from Mission Australia earlier, from the Continued Coordinated Care Program, which is, for example, a program that we work quite closely with because we do realize that a strong support and holistic treatment provision, so looking at further parts of the client's life other than just drug and alcohol, are key to long-term success and definitely part of what we call our step care approach. So increasing the supports available to the client as the client progresses through their journey and starts meeting their goals. In general, our treatment delivery is client-oriented and focused. We provide both harm reduction and abstinence-focused programs, which is important to point out. And our programs are trauma-informed and recovery-oriented. In terms of the services that we do provide across the organization, I want to touch upon our outpatient program, which is community services, as I mentioned earlier. So we run a total of 16 locations across Sydney. In the Sydney North area, we are based at Hornsby, but we also have outreach sites in Kirribilli and Narrabeen. Due to COVID-19, we were mostly based on telehealth early in the year, but we're in the midst of returning to a mixed delivery model, so having both options available to our clients, which we're really excited about. So in community services, what we offer is free support groups and free individual counselling. We've got a variety of different groups that people can access. We've got AOD recovery groups, levels 1, 2, and 3, depending on the client's experience and previous progress and success within these settings, and also smart recovery meetings. And the good thing about our internal programs is that most of these programs are quite modern and were developed within the last 2 to 3 years. which we especially find young clients respond quite well to, because they were developed with the idea of face-to-face and online delivery in mind. Another part of the outpatient community services that I should probably mention is that we also offer support groups to family members and friends. So people that are not looking to access support directly for their own drug and alcohol use, but are supporting a loved one who is dealing with this in their lives. And we also have an MOU with Family Drug Support at most of our sites. So we partner up quite heavily with them in this space. The other side of the organization, which is the residential rehabilitation program, is, of course, what most people would assume. It's a therapeutic community setting where people really stay on the premises and complete the program. So we have recently revamped. It's the biggest change in our residential program in about 40 years, which is exciting. And we have introduced a 3-month foundational program. Originally, the program was 12 to 18 months in length only, whereas now we have a 3-month option. And at that point, people can either exit the residential program and move on to our community services, or they can complete a further 12 months at rehabilitation residentially, depending on their needs and their own individual treatment plan. And we're also very proud of our Parents and Children's program, which is the only program of its kind in New South Wales where young parents can actually complete residential rehabilitation while having their kids on site, which is quite a unique program. We've seen some fantastic outcomes coming through that program in recent years, and we're also looking to heavily expand upon that in coming years, which we're really excited about. In terms of how to access the service, there's 2 ways. Clients can self-refer to our programs, both community services and residential, or there is a referral form available on our website. I always bring the referral form close to especially organizations that are looking to make these referrals, because it does include a limited release of information, which just makes things easier in terms of feedback exchange and starting that co-case management process and being able to stay in communication about how the referral was really going. In terms of how our service complements other already existing services, first of all, our community programs are free, which reduces the barriers for especially disadvantaged clients. And we have a focus on holistic treatment. So as I mentioned before, we can see a variety of clients with co-occurring conditions, and our service definitely complements mental health, disability, and employment programs in that setting. We're outside of the NDIS, and so therefore it's low barriers of entry for people. In terms of the feedback provided to referrers, as I already mentioned, self-referral, we cannot provide feedback without the client's consent, but we'll ask the clients if there's anyone that they would like us to be in touch with. With the client's consent, we can then provide a status update on their assessment, treatment engagement, and co-case management and discharge. The referral form allows us to do that off the bat. And definitely allows us to feed forward that information. So yeah, thank you for taking the time today to give me a chance to present you a snapshot of what we provide at Odyssey House, New South Wales. And I would really like to introduce our next speaker, which is Jane de Matteis, and she is the clinical lead at Brookwell Headspace.
Thank you. Good morning, everybody. Headspace is a youth mental health service that was established to address the unique barriers that young people face accessing mental health support. Headspace focuses primarily on early intervention and prevention services for young people aged 12 to 25 years, providing tailored and holistic support for the young people presenting with mild to moderate mental health concerns. Importantly, Headspace provides short-term psychological support, and it is a free bulk billing service, which makes it accessible to all young people under Medicare's Better Access program. Headspace engages a range of professionals, including psychologists, counsellors, social workers, youth access clinicians and GPs to help support young people's mental health and wellbeing. Headspace provides support for a whole wide range of issues such as anxiety, stress, low mood, relationship and interpersonal difficulties, issues around sexuality, bullying and school-related concerns. We also support young people's physical and sexual health, as well as concerns around drug and alcohol and education and employment. Headspace works closely with other local services in the community to help meet the needs of young people and their families, particularly around drugs and alcohol, employment and family support. Headspace is very much a youth-friendly service that is welcoming of young people of all identities and their families, with the centre designed to be fun and appealing. We accept referrals from many sources, including directly from the young people, families and caregivers, GPs, schools, as well as other health services. Referrals can be made by phone, email, or simply by walking into our centre. And once initial contact is made, an intake appointment is usually arranged within 1 to 2 days. If Headspace is found to be the appropriate service for the young person, then a thorough psychosocial assessment will be arranged with one of our youth access clinicians, and this usually happens within 1 to 2 weeks. Depending on the needs of the young person, they may then be referred internally to a private practitioner, such as a psychologist, for support. If Headspace is not the most appropriate service for the young person, we'll also help to ensure that that young person is linked with more suitable services, and will also ensure that it is a smooth transition to another outside service. One of the significant benefits of Headspace is the wraparound care provided by our health professionals. Young people are supported by youth access clinicians, GPs, and trained mental health clinicians who provide support and communication to the young person and their families. We also help to support young people by maintaining regular contact with referrers around treatment and outside referral pathways when necessary. Currently, during the pandemic, we moved to telehealth, but we are slowly transitioning back to face-to-face appointments. So young people have the option of doing sessions either by phone, by video, or by coming into the centre. Headspace is centrally located on the Northern Beaches and across from Warringah Mall, making it easily accessible by transport. And to help the needs of young people's busy lives, Headspace is open 6 days a week and late on Tuesday evenings. Now, team at Headspace Brookvale are passionate about the wellbeing of young people and are highly committed to supporting the community on the Northern Beaches. Our next presenters are Dr. Ryan Courtney and Professor Hayden McRobbie from the National Drug and Alcohol Research Centre.
Hi, thanks a lot, Jane, for the introduction. So Hayden and myself are based at the University of New South Wales at the National Drug and Alcohol Research Centre, and for the next 15 to 20 minutes, we'll be walking you through all things vaping and e-cigarettes, particularly related to the current evidence base and where things are up to. Slide, please, if that's okay. Thanks. So smoking tobacco. So the risks to health are almost completely from tobacco smoke as opposed to nicotine. Smokers should be encouraged to stop smoking completely. Support is available and increases the chance of quitting for good. For those that do struggle to quit smoking, there are non-combustible nicotine use is a harm reduction approach. Slide, please. So for the continuum harm, if you look at the tobacco space or nicotine space as well, with a continuum of harm, we can see on the left, obviously no use is no harm. And then to the the right, we have severe toxicity from smoking combustible cigarettes, and that harm moves its way up through nicotine or nicotine replacement therapy and e-cigarettes up to smokeless tobacco that's often used in Scandinavian or Norwegian countries, including snus. So you can clearly see there that there's a big difference between the effects of smoked tobacco versus those from products that have less harm that do contain nicotine. Slide, please. So the disease burden and costs of tobacco use are still quite staggering in Australia. Tobacco use globally is a leading cause of preventable death, around 8 million deaths per annum, and the projection of number of deaths per annum by 2030 is around 8 million. Still in Australia, we have approximately 3 million smokers aged 14 over, around a population rate of approximately 13%. And the social costs from smoking are quite enormous, actually, with $31 billion of social costs annually. Australia does have one of the lowest smoking rates globally, but we need to continue our incremental and assertive public health strategies to reduce smoking rates. So we did have a target of 10% nationally set by 2018, and now this has been reset again to 10% by 2025. And I think we need to acknowledge that there still are particularly high rates of smoking among some populations, including some of the clients, particularly at-risk youth, that some services here may see from a day-to-day perspective. And the rates of smoking are really quite high still, considering the amount of taxation and costs of tobacco over a sustained period of time. Slide, please. So there's both behavioural and pharmacotherapy options, and these two graphs here just present the increase in 6 to 12 months abstinence when either behavioural support or pharmacotherapy is adopted, all the way from unassisted, not doing anything at all, up through to both individual and group-based support. And then on the right, you've got pharmacotherapy, once again, unassisted, all the way up to currently the most effective sole treatment is varenicline, but we'll go on later to talk about vaping and e-cigarettes for smoking cessation. Slide, please. So what are ENDS? So they're battery-operated products that heat and aerosol a liquid that usually contains propylene glycol, vegetable glycerine, flavouring, and nicotine. There's generally three parts: a battery, a tank or pod for the e-liquid, and a coil or heating element. As you can see there, there's an array of vaporizers all the way through from your first sort of cigarettes to pod models and refillable models. The pod models have a replaceable pod of e-liquid activated via breathing with no pod, whereas the cigarette has usually a button. And then you've got refillable models that are larger and more complex with adjustable settings. Most smokers start with tobacco flavouring as it is familiar, and then they shift to fruit or other flavours. You can see there the pods at the top right containing nicotine solution, and then also those that contain CBD or cannabidiol, and I'll discuss that in more detail related to the Avali outbreak that happened late last year. A staggering, I think, statistic, or looking at the costs compared to tobacco. So a pack of cigarettes, around 20 cigarettes a day, smoker would spend around 10 grand per annum, whereas a simple pod device costs around $40, depending on which one you buy. And the replaceable pods can be around $3 to $6. And vaping with refillable tank probably costs close to just over $1,000. So it's probably around 80 to 90% less expensive than smoking. More recently, the Royal Australian College of General Practitioner have approved the use of vaping products containing nicotine for those that have tried other methods and failed to quit. But the climate is a lot different in Australia compared to the US, Canada, and New Zealand as well. Access is quite restricted at the moment, as nicotine is classified as a Scheduled 7 dangerous poison, and importation, use and possession of liquid nicotine for therapeutic use for those that want to quit or reduce smoking. They are legal if the user has a prescription from an Australian medical practitioner, and then they become a Scheduled 4 prescription only medication, and it's permissible to possess or use it for personal use. Then it's legal for a doctor to write the prescription, which is a lot different compared to overseas, where often these products can freely be available and bought overseas. Next slide, please. So I think it's important here, I won't go through the mechanisms of nicotine per se, but I think it's important to recognise that people smoke and smoke for the nicotine, but die from the tar. That's a famous quote from Mike Russell in the 1970s, when nicotine replacement therapies were really started to be looked into. Next slide, please. So this slide here just shows the nicotine delivery from a combustible cigarette. And then next slide, thanks. So here we're looking at the nicotine delivery from cigarettes versus some of the older style nicotine replacement therapies that have been around for quite some time. As you can see, that the peak nicotine delivery happens a lot quicker and sustained for a bit longer period compared to those with gum or the other nicotine replacement therapies. So one of the key issues, I think, with nicotine replacement therapies previously has been their ability to deliver nicotine swiftly. Next slide, please. So nicotine delivery from electronic nicotine delivery systems, in general, the faster the nicotine delivery, the more likely the product is to be more satisfying, be better at alleviating tobacco withdrawal symptoms, and have greater dependence liability. So once again, you can see some of the older style e-cigarettes or vaping products, Vuse and Inikin, were nearly performing as well as cigarettes, but not quite. So if we move to the next slide, thanks. So Juul, quite a controversial product at the moment. It's a cartridge type device that's become very popular, particularly in the US. And a recent independent study looking at nicotine delivery from Juul device among human smokers, as you can see there, found for the first time, really, we're looking at a device now that can deliver nicotine nearly as well, if not as well, as combustible cigarettes, hence probably the high user acceptability and their ability to deliver nicotine. Next slide, please. So Juul related to craving relief, once again, we look at the time on the x-axis down the bottom, and then on the y-axis on the left, the urges to smoke. You can see once again that its ability to relieve cravings is quite substantial. Juul relieve craving almost as quickly as combustible cigarettes, but currently there are no trials that have examined the efficacy of Juul for smoking cessation. But these data suggest that they could be helpful when used to assist people that wish to abstain from combustible cigarettes or quit smoking. But obviously a possible downside to this is long-term use may be more likely given its ability to deliver nicotine so well. And we need to balance the risk of uptake, especially among non-smokers. Next slide, please. So there was a recent outbreak in the US. The first cases occurred in August 2019. As you'd be aware, it received high media attention and public interest, and it was called the EVALI outbreak, or e-cigarettes or vaping product use associated lung injury is what EVALI stands for. And by February 2020, there were over 2,800 cases of lung injuries and 68 deaths across all 50 states. And as you will notice that originally there was a lot of hype and indications that all types of vaping, particularly even cleaner forms of e-liquid containing nicotine, was harmful. However, on further scrutiny of the case reports and the data presenting to hospitals, it's clear that vitamin E acetate was found to be heavily associated with vaping-related illness. And vitamin E acetate is an oil derivative used in vaping products as a thickener. And vitamin E acetate usually does not cause harm when ingested as a vitamin supplement or applied to skin, but when inhaled, interferes with normal lung functioning. And the Centers for Disease Control has urged everyone to avoid e-cigarettes or vaping products containing tetrahydrocannabinol or THC. So the take-home message after we synthesised, or the literature has really been critiqued, is that don't add substances to e-liquids, as we can see what the catastrophic effects have been for those that do add THC. Next slide, please. That's the update on the Avali situation, but it really led to a slightly changed landscape, with some countries actually banning e-cigarettes, and obviously in the US as well, some banning of flavours. But Public Health England continues to endorse e-cigarettes as a safer option than cigarettes. Next slide, please. So this is a bit of a thought-provoking question, though. Is it time to realign our approach? From one of the most respectable journals in the field, surely is it time to align the public health approach, e-cigarettes, with that of cigarettes? So I'll now pass on, next slide, please, to Hayden McRobbie now.
Thanks, Ryan. And just, I guess, to recap at this stage, that there are a whole wide range of electronic cigarettes or vaping products, or the other terminology that Ryan used was ENDS, which is electronic nicotine delivery systems. They've changed over the last 10 years or so that they've been available. And now we see that we've got products that can deliver nicotine efficiently and as quickly as smoking. So this would be a really good thing for people who want to quit smoking, but potentially a bad thing if you've got never smokers that are starting to use these products and get hooked on them. So you can see where the questions come, and perhaps the debate from two sides of the fence. But first of all, I'm just going to talk about the question, can these electronic nicotine delivery systems actually help people stop smoking? If I can have the next slide, please. This is just going to review some of the evidence from the Cochrane Library, the systematic review on electronic cigarettes, specifically for smoking cessation. And this update was published earlier this month. Next slide, thanks. So the review, what did it look at? Well, this review includes evidence up until January 2020. And it includes randomized controlled trials, which generally give us the best and most reliable evidence when we're looking at the effects of treatment. And these trials compared electronic cigarettes with nicotine compared to electronic cigarettes without. They also compared e-cigarettes with other products such as NRT, your gum, your patches, your lozenges, etc. And there was also a couple of studies that looked at using electronic cigarettes in combination with nicotine replacement therapy. We also included some cohort studies, especially for our outcomes that looked at safety. What these studies had to include was at least 6-month follow-up. Because you want to see longer term, or this is medium to long term smoking cessation. And when the studies were looking at side effects, they needed to include follow-up for at least a week. Now, this update included 50 studies, over 12,000 adults who smoked. And this review is actually a living review now. So we're going to be running monthly searches from next month. So it looks like we'll have a happy Christmas and New Year looking at more of the evidence. Fingers crossed there isn't too much more to look at. But this gives us a chance to update the evidence as we go, as opposed to waiting for another 4 years, which is what we did. Next slide, please. Okay, so I just want to share the headline results here. So overall, the evidence that vaping products or electronic cigarettes can help people stop smoking has been strengthened. And it's because we've got a few more studies now to include in the analyses. So the headline results are that more people probably stop smoking for at least 6 months using nicotine e-cigarettes than using nicotine replacement therapy or using nicotine-free e-cigarettes. So the evidence is, we're fairly certain around this, which is why they probably help people stop smoking. The evidence that e-cigarettes are more helpful than no support or behavioural support only, we're less certain on. So we would like a bit more evidence there before we can raise that certainty. But in general, if 100 people tried to quit smoking using electronic nicotine delivery systems, then we can expect that around 10 people would stop smoking long term. Compare that to 100 people using nicotine replacement therapy, around 6 would stop smoking long term, and out of every 100 people that use behavioural support or no support at all, around 4 people would stop smoking long term. And those figures are about right to what Ryan showed you before. Overall, though, I think you can appreciate here, we're not talking about magic cures or silver bullets. Stopping smoking is a very challenging thing for many people to do. And although we've got some evidence now to show that e-cigarettes can help people stop smoking, you can see that long-term quit rates still remain pretty low. Next slide, please. In terms of adverse effects, there are very low numbers of adverse effects across all study groups. So we couldn't really determine any true difference between users of nicotine-containing e-cigarettes versus NRT. What we do know from these data are there are some common side effects of e-cigarette use. These are mostly short-lived, but include things like throat or mouth irritation, headache, cough, and nausea. We didn't find any significant difference between the groups in terms of serious adverse events. Next slide, please. So, summary findings here, and this is directly from the Cochrane review. ENDS or e-cigarettes probably do help people stop smoking for at least 6 months. They probably work better than nicotine replacement therapy and nicotine-free or zero nicotine electronic cigarettes. They may work better than no support or behavioural support alone, and they may not be associated, their use may not be associated with serious unwanted side effects. But just to caution, the 2 bullet points there at the end where we've got may, it means there's still some uncertainty around the evidence. Next slide, please. In terms of real-world evidence of this, there are some studies both that both support and don't support what we found in the Cochrane review. But first up, here's some data from the UK. Large sample size here of over 18,000 participants. And when they looked at smokers that had made a quit attempt in the last 12 months and what they used, there were 2 particular interventions that were found to be associated with quitting, and that was e-cigarette use and varenicline or Champix. And actually, varenicline is currently the most effective aid for smoking cessation. Next slide, please. Another example here, this time from the US, and these data from the PATH study. And essentially, the key message here is that at a population level, e-cigarette use by smokers, and especially those with chronic medical conditions, was associated with more quitting activity and also quitting smoking. So those that were using e-cigarettes were more likely to make a quit attempt, and if they were using e-cigarettes, more likely to quit than if they weren't using e-cigarettes. Next slide, please. I just want to mention safety here because I think this is something certainly my patients always ask me, do they help me quit smoking and are they safe? I think the key message here is they're not 100% safe. What I like to say is that they are less harmful than smoking. Next slide, please. Oops, if we can go forward again, thanks. In terms of health risk, and these were the conclusions from a big review done in the US a couple of years ago, and they concluded that actually e-cigarettes weren't without risk, but less risk than tobacco. So it all depends on where you're coming from. If you're a smoker, if you're a current smoker who switches completely to vaping and stops smoking, then you will expect to see a reduction in your health risk. However, if you're a never smoker, especially a young never smoker who starts vaping and becomes a regular vapor, then there is likely to be some long-term health risk associated with that. However, we're not exactly sure of what that level of risk is, and it will take some years yet until we fully understand that. Next slide, please. There are substances that are potentially harmful. For example, if you overheat vegetable glycerin, then you can get aldehyde formation, which are toxic and irritant to the respiratory system. There are metals in the devices, such as the battery, obviously, and the heating element that aerosolizes the liquid contains metal, and so you can get metals appearing in the vapor. The liquids, nicotine's probably the least of our worries, although of course you want to keep these high strength nicotine products out of the reach of kids. But it's probably going to be the flavorings that will cause most concern. And we already have an inkling from data so far that some of the flavorings, for example, those listed there, that may be more problematic than others. Next slide, please. But I just wanted to also highlight that the presence of these toxicants doesn't necessarily translate to harm, because harm's related to exposure. And this is the same with smoking, of course. And you will know if you stop before the age of 35, then your risks of smoking-related illness revert to that of a non-smoker. It's really once you've had many years of smoking and exposure to toxicants that the smoking-related illness appears. And this is going to be the same with vaping. And that's why we haven't seen any concerns or serious concerns come up with vaping-related illness yet. But perhaps after another 20 to 40 years of use, maybe we'll start to see these start to emerge. A complicating factor to all of this is that most people who vape are either current or former smokers, so trying to tease that apart will be a little bit difficult. Next slide, please. In terms of offering help to people who smoke, this goes across all age groups. If you have someone who smokes, then make sure you're first screening for smoking or tobacco use. For those that do smoke, give brief advice. Explain what you can offer. And in general, the best thing that you can offer is a combination of stop smoking medicines and behavioural support. So nicotine replacement therapy with quitline, for example. I'm in New Zealand, we've got a very good local stop smoking service, so I try and encourage people to get down there. But occasionally you will get people that ask about e-cigarette use. And I always say, look, is it okay if I tell you what I know about them? Because my job is to try and get through the murky details sometimes and try and communicate what I know, and it is this: they can help people stop smoking, but they're no magic cure. So some effort's still going to be needed. I know that they pose less risk than tobacco smoke, but we don't know the health risks that might be associated with long-term use of electronic cigarettes. And of course, any electronic cigarette, nicotine containing or not, shouldn't be used by people who don't smoke. Next slide, please. In terms of people are going to use e-cigarettes or ends for stopping smoking, then daily use is generally associated with better outcomes. More advanced models that deliver nicotine more efficiently tend to work better. That people should read the instructions from the manufacturers and keep them safe. These are electronic devices. You shouldn't use them in the bathtub or anything else like that. Don't carry coins around in your pocket with the batteries. That's where things go wrong. It does take a little bit of practice to learn to use the device properly and to get the right amount of nicotine out of it and relieve your urge to smoke. And I think one of the best messages you could give would be to stop smoking combustible cigarettes as soon as possible. And because we don't know the long-term risks, then I always advise people to, as soon as they feel safe, they're not going to go back to smoking, aim to stop using electronic cigarettes as well. Next slide, thanks. And don't forget to document all of this. Remember, use of electronic cigarettes is not a combustible product. So if someone has completely switched from cigarettes to e-cigarette use or ENDS use, then they should be categorized as an ex-smoker. But if they're still smoking cigarettes, then they remain a current smoker. Next slide. And just to finish, so in summary, e-cigarettes, yes, they can help people stop smoking, but not a silver bullet. They are likely to be associated with some adverse health effects in the long term. So concerns warranted here, but we always have to balance up the potential risks of long-term use versus the risks of current smoking in people who smoke. And for smokers who do manage to switch, the key message there is to stop smoking completely, and that this is likely to be associated with a reduction in the health risk. This is supported by the literature, but as I said, to mitigate any concern over long-term health risks, advise people to stop vaping as soon as they're able to not go back to smoking. And that's it from Ryan and I. Ryan, I don't know whether you want to add anything else to that. Otherwise, we'll hand it.
Yeah, happy to hand over. Thanks.
Back to Pat. Thanks.
Great. Thank you so much, everyone. This is now an opportunity for some questions for any of the speakers. So if it is for any of the particular services or for Hayden or Ryan as well in regards to e-cigarettes, please send them through. Now, I do have some questions already. So while we go through those, I'll leave it to everyone else to keep submitting your questions through. And I guess this is just a general question to a lot of the services. And the question was around fees for service. Now, I know most of our services are all free. And some services have highlighted that they are linked in under Medicare. I might put the question out to all the services. If you have a service that does require a fee, I'll get you to unmute yourself and just let us know. Otherwise, all the rest are free of charge. So I'll put that to the panel just to see if there are any services that do cost.
So I'm happy to jump in there in regards to Odyssey House, New South Wales. The community services, so outpatient program, is completely free of charge. But the residential services, so the therapeutic community, the 3-month and 12-month residential program, as well as our internal medicated withdrawal units, do come at a subsidized fee, which is affordable by people on benefits, for example. So people on benefits will forfeit 60% of their benefits for each fortnight, which would cover the entire cost of the program. Or alternatively, if people are not on benefits, they pay $480 per fortnight, which again covers the entire cost of the program.
Awesome. Thank you, Christian. I'm not sure that I don't think there was anybody else that had a fee for their service. So I guess the key message there to the viewers is a lot of our services are free and are there to support young people and the community. So I would encourage you to get in touch with the services to chat through any potential young people that you feel are in need of support. Another question I've got as well is around consent and young people. So I guess, again, a question to some of the services out there that work with the younger sort of age bracket is, do you need consent for a young person under 18 to access your services? And I think I might just go through and name some of the services here and I'll get the people to speak. I guess I can speak from a day's perspective, and we only require consent from young people under the age of 16. However, if there is a risk of harm for getting consent, we can workshop through scenarios as to how we might enable that young person to get the support that they need. I might just name some of the services in regards to SDEC. Carolyn, do you want to let us know what you guys do in regards to consent?
Yeah, no, we only need parents' consent for under 14, so 12 and 13-year-olds we do, but for 14 years and upwards, we don't require that consent.
Thank you. And Headspace?
It's standard practice that we have consent for young people under the age of 16.
Great, thank you. And Kim's?
Consent kind of gets tricky when you're dealing with the severe and complex end of the spectrum sometimes. So we always need consent to work with clients and young people to liaise with their families. However, when their safety is at risk, and the Mental Health Act, for example, is activated, then risk outweighs consent. And so under Chapter 16A, health and education and police and schools can share information, but the best practice, of course, is that we always request consent and work hard to encourage people to make informed consent to service.
Awesome. Thank you. I guess some other questions here in relation to vaping and e-cigarettes, and I'll put this out to anyone on the panel. The question is around, what would you say are the key messages to young people in schools who are vaping? Anyone would like to contribute to that question?
Maybe it's Hayden here. Maybe I can start because there are a few questions that have come up here. I think we need to be very clear with our messaging that for people who do not smoke, they should not vape, or to the contrary, vaping is for people who smoke only. And I suspect that the message has been slightly blurred in that when, for example, Public Health England have said, well, they're 95% safer than smoking, that message has come across as that vaping is safe. Vaping is not 100% safe. It's less harmful if you smoke, but if you don't smoke, there's likely to be some harm. We don't know what that is yet, but there is almost certainly going to be some degree of harm associated with long-term use. And I think someone also raised the fact that these people are in the US have become addicted, especially with using products like Juul, which, as you can see from Dr. Courtney's presentation, can deliver nicotine really quickly and is almost as good as smoking. So I think this is where we've seen in the US this uptake of especially these very efficient nicotine delivery systems in young people that don't smoke. The other difference, of course, in the US too, is there's much less control in terms of their advertising. Only recently have they started to look at restricting this. If you look at the EU and the United Kingdom, there have been regulations in place since 2014 with the Tobacco Products Directive, which limits sales to those over age 18 or 18 and older. They limit any advertising, and they also limit the maximum concentration of nicotine that can be contained in these devices. And the UK, at least, hasn't seen this large increase in young never smokers starting to vape. So I think that it's going to be a difficult time. Just a comment from Natalie about prosecution of people. Are the police notified? Will the students be legally implicated? That shouldn't be the case. It should be the sellers that are visited by the police and not the people themselves. So some education around all of this, I think, will be absolutely critical. It's going to be interesting in Australia versus New Zealand. In New Zealand, we have our Smoke-Free Environments Act that's been amended and will come into force on the 11th of November. This does allow the sale of nicotine-containing electronic cigarettes, but not to minors. Advertising will be banned, and also flavours will be limited as well. So there's a number of different steps that will be implemented at different time points. I hope I've answered some of those questions.
Thank you so much, Hayden. I know from a day's perspective, we do offer schools support in regards to AOD education, and we have recently sent out an e-cigarette and vaping package to schools in regards to how support can be implemented. So, you know, please get in touch. Is there anything else anyone would like to add from the other services around that space before we sort of wrap up? I know there are a few other questions, but what we'll do is we'll try to get around to those questions via email so that we can provide a response. But I do want to just, before we finish up, put it out to the other services to see if there was anything else that they would like to add on the topic. No? Okay, I might just hand it over to Pat for us to wrap up.
Thanks, Michelle. This webinar recording will be available on the Sydney North Health Network website in approximately 2 weeks. Thank you to all our presenters, great job, and to our audience for taking the time to be with us this morning.